My name is Michael Cain. I'm a clinical electrophysiologist, and I serve as Vice President for Health Sciences and Dean of the School of Medicine and Biomedical Sciences at the University at Buffalo in Buffalo, New York. I just recently presented at the International Academy of Cardiology annual scientific sessions, and also this is the 20th World Congress on Heart Disease that's been held here in Vancouver. And the title of my presentation was an update on what's new regarding the 2014 American Heart Association College and Heart Rhythm Society guideline for the treatment and management of patients with atrial fibrillation. And those guidelines, in my role as a clinical electrophysiologist, made 8 important points that I wanted to convey to the audience. One was a change in the risk stratification approach used to identify those patients with atrial fibrillation at highest risk for stroke, and that was to move from the CHADS score into a CHADS VASC score, which includes 3 additional important factors. One is the presence of vascular disease any place in the body, a continuum of age rather than just picking 75 years as a single point of risk versus no risk, and 3, the importance of female gender as a risk factor. The second was using this new CHADS VASC score, that those patients who have a score greater than or equal to 2 or who have hypertrophic cardiomyopathy, regardless of their CHAD VASC score, do need to have treatment with anticoagulants that can include the traditional warfarin or newer type agents that work as thrombin inhibitors or factor 10A inhibitors. The third point is that those patients who have a CHADS VASC score of 0 really do not require anticoagulation, and that's an important new point in the management of patients with atrial fibrillation. The next point was that the newer anticoagulants should not be used for patients who have atrial fibrillation and have prosthetic heart valves. These drugs can actually do harm in that situation. Another point is that the guidelines stress is the importance of having adequate ventricular rate control in patients who have atrial fibrillation if one chooses rate control as the management pathway for trying to reduce symptoms, and that this rate control needs to be not only the heart rate at rest, but also the rate control during exertion. And so it's a more stringent recommendation to make sure that the ventricular rate during atrial fibrillation is really controlled throughout the 24-hour period. The use of antiarrhythmic drugs for trying to restore or maintain sinus rhythm has essentially unchanged from guidelines that were published in 2006. And then the final point, which is a newer approach, a relatively newer approach, which is the use of catheter ablation for the cure of atrial fibrillation, has maintained its role in treating patients who have paroxysmal atrial fibrillation and who are highly symptomatic and don't respond to at least one antiarrhythmic drug. And that guideline stays the same from that which was published in 2006. But a newer guideline is that as more evidence that catheter ablation is effective, that patients who have highly symptomatic paroxysmal atrial fibrillation, that in those patients catheter ablation can be considered as first-line therapy instead of making the patient first see how they respond to a drug, as long as the ablation is performed by truly experienced clinical electrophysiologists in well-established clinical electrophysiology laboratories.